Anal fissure is quite a common condition, mainly in young people between 25 and 45, but not exclusively. Anal fissure is simply the tear. It is a split which appears to be in the anal canal, which is the ring of a sphincter of our back passage, and that is a place which, interestingly, from the whole body, human body, is the most sensitive for pain. In terms of the symptoms, the most dominating one is pain. That pain can be mild, but in most of occasions we see patients who really suffer from very intense pain, almost debilitating pain that can be lasting for a few days, few months. But on occasions we see patients who suffer even more than 1 year. That's on the questioning and taking the history from the patients. Again, most of the cases, this pain is described very accurate way as a sharp, as a burning, and as a throbbing. And most of the patients are describing this like a passing razor or passing the pieces of glass. And when the experienced surgeon hear this, the diagnosis is almost done, because without any further investigation, because this is such a typical textbook description. So I believe that experienced surgeon is almost able to make a diagnosis just based on this information. Well, the diagnosis in most of the cases is very simple, as long as surgeon knows what to look for or what he should be looking for. Just a simple rectal examination, which takes 10, 15 seconds, and of course doesn't cost anything, and can be done simply in any consultant room or outpatient setting. Rectal examination is typically showing very high or unusually high stretch of the anal sphincter muscle, which is the involuntary response to that intense pain. That is the first. And the second is that the patients are experiencing very intense pain, mainly. The fissure is about 19 out of 20 cases positioned on a posterior wall towards the coccyx, which is caused by the fact that from the anatomy point of view, this is the spot of the anal sphincter which is least perfused by blood. That means that this is most vulnerable spot. As I said, it is most common location, and if the fissure is found in any other place around the ring of the anal sphincter, it is always advised to investigate the patient further for some possible underlying condition, mainly Crohn's disease, ulcer colitis, but sometimes something even more serious. Anal fissure is a condition that we still don't know enough, and we, as a surgical society or community, we still don't know what to offer our patients best. It is believed that on very rare condition, the fissure can heal spontaneously, but we rather believe that the symptoms settle, so the patient doesn't have any problems, doesn't experience any pain. However, that fissure can be silent and can flare up any moment. Fissure is, as I said, a condition that we still don't know enough, despite the researches, despite the random trials to look into the best options what to offer our patients. However, our society, which is called Association of Colorectal Surgeons of Britain and Ireland every year issues the updates on optimized medical and possibly surgical treatments. The management of anal fissure currently has 17 recommendations, which means that again, that is a condition which is very variable, and indeed we don't know how to help our patients best. However, our last colorectal meeting in Manchester last year issued the recommendation or sequence of recommendations. These are based only on experience of the most experienced surgeon in this country. However, these advices or management is not proven by any randomized trial. It has several steps. First step, of course, once the fissure is safely diagnosed, is to improve the lifestyle in terms of the fluid intake, which should be at least minimal 2 liters a day, excluding coffee, and reasonable fiber intake. That is the first step, which of course is very simple and anyone can do it. If this doesn't help, then the surgeon needs to get involved. We can prescribe patients the creams. This main one we use in England is called diltiazem, and that is a cream that needs to be delivered into the back passage to get in contact with the fissure, and the cream works the way that it eases off, relaxes that long-term lasting overspasm, which means that we are achieving the normal blood flow around this wound, and by the simple surgical logic, where is the blood flow, there is oxygen, where is oxygen, there is healing. So that is a second step in sequence of management. If this one doesn't help, then patients are recommended to have the fairly minimal case, but under general anesthesia, where patient is put to sleep, all his muscles are paralyzed, and we use the Botox, which is a botulotoxinum, to inject into the muscle. And again, that has the same effect as a cream, however more pronounced, which is achieving to relax the muscle as such. That is a safe procedure that takes about 10 to 15 minutes. Unfortunately, it should be performed under general anesthesia, and recovery is straightforward. We see improvement in some patients almost within the hours, and some patients need about possibly even 2 weeks to improve. After this procedure, patients should be observed for about 6 to 8 weeks. And if this doesn't help, but the patient doesn't get healed, then the recommendation of our society is to maximize the dose of the Botox, which comes up to 100 units of the botulotoxinum, and repeat the same procedure, however, with the highest possible dose. The procedure is happening exactly the same way, but however, this maximum dose already can have some side effects, which is the weakness of the anal sphincter, which can give patients some discomfort. However, according to the literature, according to the overall experience, this negative effect wears off between 6 and 10 weeks. Even if this doesn't help, then patients should be referred to a more specialized center, because after being resistant, the fissure being resistant to these 3 traditional steps of treatment, it is understood that there might be some even inherited underlying condition that is avoiding the fissure to get healed. And for this reason, patients should be refer to the centers where more sophisticated investigations are available. Mainly, these tests are called endocrine ultrasound. That is indeed the ultrasound probe that investigated the nature and integrity and the strength of a ring of the anal sphincter. And the second one is called anorectal physiology, and that is even more important test, which is measuring the natural tone, the natural strength of the sphincter itself. And yet again, that can give us far much more details and information how to go further. Next step again in our recommendation is then to perform again very small surgical procedure under general anesthesia, which is called lateral sphincterotomy, which indeed means to virtually cut by scalpel the small portion of the muscle. That is the operation that clearly has the dark sides. Patients can have some leakages or discomfort or seepages, and therefore this operation should be always very carefully judged, and then should be, of course, very carefully discussed with the patient. However, I am stressing again that this should not happen any other way than after these two quite complex investigations. Fissure is unfortunately a condition that can recur, and from overall understanding and from overall experience, the typical patient are the young people who are under stress, typical around the A-levels examination, being in the university. However, it's not exclusive. We even see patients in their 60s and 70s. In terms of the complications with the anal fissure, first of all, and again, I can't stress enough from my 35 years of experience, we need to be certain 100% that we are dealing with the anal fissure as such, and that we are not missing any precancerous or even cancerous condition that on the direct vision can on occasions look very similar. So that is the first clearly very important thing to be certain about. The treatment doesn't have that much of that many of a complication. Clearly, plenty of fluids and reasonable fiber diet are the condition that of course can help any one of us. Using the cream is the situation which can have the side effects in terms of the very severe headaches, to the point that some patients have to disconnect the treatment. Further on, the other three options are under general anesthesia. That means that these risk of the fairly minimal, shallow and short anesthesia we can't take away. They are usually very, very low, but they are not zero. And of course, allergy is always the exception, again, very uncommon. And that could be, in terms of using the Botox, that could be just a temporary symptoms of the weakness of the sphincter. But as I said before, when the muscle is cut, then of course these damages or impairment of the function is long term or possibly for life.